Hey guys, this is Dr. Mahajan from Mahajan Medical Center. I'm very excited. We got a very prominent guest, Dr. Shetye, today. He's a well-known local nephrologist, a kidney specialist, and we're going to be talking today about chronic kidney disease. And if you don't know me, I'm Dr. Ranjan Mahajan. I'm a board-certified internist here in Largo, Florida. We do once a week webcast, and we try to bring different thought leaders to help our patients, help our community understand the diseases better and see if we can make a difference in their disease outcome, more importantly, for better quality of life. So do comment. We're going to do a raffle end of the show. If you put comment, I already see Stephanie said hi, Dr. Mahajan. Hi, Stephanie. You know, more people comment, more your chances of getting the $25 gift card we raffle end of the show for the publics. So, let's get started. Let's introduce Dr. Shetye. Before, let me give a brief introduction about Dr. Shetye. Let me share a screen. Uh, uh, here. All right, so here's, all right, let's just make this bigger before we bring him in. All right, so as you can see, Dr. Shetye is a nephrologist and he's been in the community for many years, and he has been serving as assistant professor of medicine for the Nova Southeastern University. He teaches the residents at Largo, Florida, Largo Medical Center, and also teaches nephrology. He is also medical director at Fresenius Dialysis Center, and also affiliated with the DeVita Bay Breeze Largo. So he has wealth of experience. Without further ado, let's bring Dr. Shetye in the mix. Hello, Kedar.
How are you doing, Rajan? Thanks for having me. I'm happy to be here.
Yes, so tell us something about yourself. What got you interested in nephrology or kidney disease?
That's interesting. I always wanted to do chemical engineering as a kid, but somehow or the other, I found myself in a medical school at the end of all that. And nephrology, dialysis, fluid, and electrolytes came closest to my passion of chemical engineering, some which way. So I found myself in a fellowship at Johns Hopkins, and 5 6 years later, here I was in Florida, starting my practice with as a part of the Renal Hypertension Center on the west coast of Florida.
So you moved from South Carolina, right?
Right. So initially, when I finished my fellowship, I was a little more interested in academics, so I was on faculty at the Medical University of South Carolina for 5 years. I wrote several papers, taught the residents there, did a lot of CME programs. But then we wanted to move to a slightly warmer climate, so the family and I we moved to here the west coast of Florida back in 2006, and this is where I've been since then, and hope to be here for the rest of my life.
Great. Um, so let's start it on the kidney disease, chronic kidney disease. Uh, as I was alluding to earlier, chronic kidney disease is a form of inflammation involving kidney. If you look at the age group between 65 to 70 years old, one in five, one in four, depending on women or men, have established by 19 age, 50% have acute kidney disease. So this is a disease that connecting kidney
Rajan, can you speak up a little bit? I'm losing you
Okay, can you hear me better now?
slightly. Yeah,
Okay, how about now?
that's much better. Thank you.
Okay, so I was talking about why the prevalence is important. National Kidney Foundation has a 33% campaign that if you're on the road, people next to you, the 33% people may have chronic kidney disease. So that makes it so important to discuss this topic about kidney health. So what are the common conditions which in your practice you see patients start getting their kidney affected?
That's a great question. So, the kidney disease affects about 37 million Americans right now. In other words, this is not the at risk population. These are actually people with various stages of kidney disease. That's 37 million people. And that's roughly about maybe 10 to no, probably about 12 to 13% of the population. In addition to these people who are with kidney disease, there's a huge population out there, which, as you said, was 33% of the general population, which is at risk for kidney disease. Now, these are patients with hypertension or diabetes, which are responsible for about two-thirds of the patients with progressive kidney disease. So the National Kidney Foundation is right on the ball when they say 33% of the population is at risk for developing kidney disease in the future. And as you know, as a country, we are living longer and longer each passing decade. And the older you get, the risk of kidney disease goes up, in part also because the incidence of hypertension and diabetes goes up. So, in addition to aging, hypertension, and diabetes, some of the other risk factors would be medications that are taken on a chronic basis, like over the counter analgesics. Virtually all of them cause kidney disease, with the exception of acetaminophen, popularly called Tylenol. So, those are some of the common risk factors we review when people come into my office for evaluation of chronic kidney disease.
So, in summary, if I get you correctly, diabetes is a biggie, high blood pressure is a big one, obesity, smoking. Let's see, you talked about NSAIDs or, leave, ibuprofen, those kind of drugs. And then familial, which is we don't talk as much, polycystic kidney disease and things like that. But you'll catch earlier in them. And I think the important point, I want to bring up, it's a silent epidemic. Why it's called silent epidemic, Kedar?
Well, most people are unaware that they even have kidney disease. Uh, for that, it's important to understand, and we'll be going into the stages of kidney disease in just a minute. But the earlier stages of kidney disease, stage one, two, or three, you rarely have any symptoms. Most patients are completely unaware that they have any internal organ damage. Even after we tell them that the numbers look worrisome, the patient's first reaction inevitably is, "But I don't feel anything." And that's very commonplace. And so part of what we do in the clinic is to educate patients that in the initial part of the kidney disease, we have to look at the numbers. By the time the symptoms start showing up, it's usually very late. You're either in stage four or the last stage, which is stage five of chronic kidney disease. You tie that in with hypertension, which is also a silent killer, with diabetes, which is often asymptomatic. And you can see how kidney disease itself also progresses very quietly for many years before it comes to light. So catching it early is vital in diagnosing and treating kidney disease.
So, you brought up a lot of great points. Let me summarize because you know it, as your back of your hand and, you say it quickly. So I'll just keep highlighting the key points you're hitting. So the people need to understand that it's very common as you get older, and a lot of our, as county, the population geriatric. So you may not have any symptoms. So that's very important to understand. So it's very important at least once a year, even if you're healthy, get your annual physical done through your primary care or internist or ARNP, whoever you're seeing, and get your blood tested and get your urine tested if you have risk factors like your mom is hypertensive or your parents have chronic kidney disease in their early onset. So you want to make sure you catch early. So while we're talking about catching it early, let me bring the slides you brought for the, in terms of what does it mean for the staging, and we'll go over that quickly. It's more technical, but a lot of people know about it because over the years the National Kidney Foundation done a good job with educating people. Here we go. So the stage one, so this is based on your EGFR or your glomerular filtration rate, and you don't need to do anything. The good thing is with 10, 15 years ago, there was a lot of aggressive campaign about including this number in the labs, the standard CMP. So, with that, and also there was a very important piece of differentiating between Afro-American and non-Afro-American because, the EGFR is different in different races, and we'll talk about that with Dr. Shetye in a minute, how the different races affect or the culture affect kidney disease as well. So stage one, you don't need to worry, but you got to start taking care of yourself in terms of weight, in terms of blood pressure, in terms of sugar. Your EGFR is more than 90. Stage two, still okay, but it's something you got to be more aggressive and follow up. 89 to 60. Now, stage 3A, that's something you got to start, being extra careful about your diet, and we'll address that with Dr. Shetye, the diet, and what are the other things we can do to slow down the decline. And now the EGFR is 59 to 45. And then the next stage is the stage 3B, which is again the kidney function declining. So we're getting away from looking at the creatinine, we're looking at EGFR, and we'll talk to Dr. Shetye why it's more accurate, but let's just hold off on that question. And then stage 4, now we're in trouble. Now the kidneys are getting tired, and you got to start looking at help of a good nephrologist like Dr. Shetye to make sure there's nothing we can do to keep you there, because once you get to stage 5 or end-stage renal disease, the choices, and we'll discuss the treatment option, what's new in that field, but now your options are getting less. um, did I miss anything, Kedar, on the staging?
Now, that was great. Uh, the reason we changed from creatinine to the GFR was because it was often hard for patients to understand what creatinine meant. So I'm just going to explain the creatinine concept in one or two sentences. Creatinine is a natural molecule that all of us produce. Our muscles produce it, and the kidneys excrete it. So what we do in the lab is measure how much creatinine is in your blood. The inference being, if you have a high creatinine, it means your kidneys are not excreting the creatinine well and you have a kidney problem. But often patients have a hard time understanding what a creatinine number actually translates into. So what the Kidney Foundation did about 15 years back is it came up with a new way of explaining kidney function. You take that same creatinine, you take their age, gender, race of the patient, and it comes out with a very accurate estimation of how much kidney function you have left on a scale of 0 to 100. Now, all of a sudden, patients they find it much easier to understand what a kidney function of 80% means versus 40% versus 15%. And we have it staged accordingly, as Dr. Mahajan just showed on that slide. Stage 1 and 2 are very early stages. You perhaps don't need to visit a nephrologist, but your primary doctor can guide you in those first 2 stages with tight control of blood pressure, diabetes control, weight management, smoking cessation, some dietary changes that I'll go to in a minute. Stage 3 is when patients should start being referred. Not all of them. If you have a stable patient with stage 3A, such as a kidney function between 45 to 60%, I think a good internist like Dr. Mahajan should be able to manage them very successfully in their office. There are some exceptions, but a good internist, again, would know when to refer them even in stage 3A. Stage 3B is when things start really getting serious. Some stage 3A should also be referred, but stage 3B, I think referral should start, because this is where the kidneys are more or less becoming, the kidney function is getting worse in a way that I think it needs a specialist to try and change the course of the disease process. So when you come in with stage 3B kidney disease with a kidney function between 30 to 45%. We take a good history look at your family story. We look at the urinalysis because a lot of times the urine picture will tell us if there's any inflammation in your kidneys or if you have protein excretion, if you have any blood in the urine, which again is often a clue as to any malignancy that might be brewing in your kidneys. So stage 3B is the point where a lot of patients should start coming to the specialist. Definitely stage 4 and stage 5, the more advanced stages, the internist and the nephrologist will have to work hand in hand to have a better outcome for the patients.
Let's get you a comment to make you happy, Kedar. Here we go. Stephanie is saying, "Hi, Dr. Mahajan. Hi, Dr. Shetye. Thank you for taking care of my mom when she was alive. Very useful information." Thank you, Stephanie, for watching. And it was an honor to take care of your mom.
Thank you, Stephanie.
And then we got Vincent saying, it's related to my practice. I'm a hemodialysis nurse. So, there are a lot of team approach, and we don't give credit to the dialysis nurses. They do a fantastic job in keeping the dialysis patient. And a lot of time they have long-term relationship with the dialysis patient, and they keep them in good health. What's your take on that, Kedar?
Well, nurses like Vince, I mean, I know Vince personally, and he's a splendid nurse. Nurses like Vince are invaluable. The physician can't be in the dialysis unit all the time. And the nurses, we rely on the nurses to relay to us any unusual occurrences or any complications with dialysis. The dialysis nurses are probably an underappreciated segment of the whole dialysis industry. Without them, it's just not possible. The nurses are also invaluable in educating patients about salt restriction, fluid restriction when you are in end-stage renal disease, and of course, giving advice on medication management after discussions with the physicians. So I think it's one of the three legs that the doctors, the nurses, and the patients, each one of them is an important component of this life-saving procedure that has become so commonplace now.
Let's bring another comment in the same vein. Amy is saying, "Easy doctor to work with. We appreciate all the nurses." So same thing, she works at the Vita at Largo. Thank you, Amy, for watching the webcast. Let's move on to, something I want you to, take it by bull's horn. So let's say you have a patient now, Kedar. You walks to my office, asymptomatic. I do a blood test, and their EGFR is 30. They're in their 70s, doing well otherwise. Borderline high blood pressure under control, and they are asking me, "Hey doc, what else we can do so I don't end up on dialysis?" So let's talk from there now. They know that they have it. We established that they're almost stage 3B or close to stage 4 almost. What are the things we have? Diet, exercise, quitting smoking. What else you can tell them to hydration? Different aspects you can suggest to them that will help them to stay in a stage 3B or 4 and not get to the hemodialysis or kidney transplant if they're younger.
That's an excellent question. That stage 3B or stage 4, in other words, a kidney function between, let's say, 45 to 15%, that's when we can intervene before things take a turn for permanent dialysis. And it's very crucial that patients not only come for their nephrology appointments, but also abide by the advice given. Things that actually change outcomes for the better, in other words, delay dialysis, are mainly diet and fluid and salt related. Of course, the physicians will be prescribing medications such as an ACE inhibitor, like lisinopril or losartan, to slow down the damage to the kidneys. The physician will be prescribing blood pressure medications and diabetes management. But as a patient, I think some things that are absolutely invaluable are to cut down on your protein intake. Now, the moment I say that, a lot of patients get a little worried. What if I get malnourished? So the first thing to remember is most Americans get twice as much protein as they need in their diet to start with. So cutting back on your protein intake is not going to make you malnourished or weaker or make you lose muscle mass. But excess protein intake can definitely put stress on your kidneys. Great studies have shown that lowering the amount of protein in your diet actually delays the onset of stage 5 kidney disease or the need for dialysis. Along with lowering the protein in your diet, one also has to lower their salt intake. Salt is tied to blood pressure, but more importantly, salt intake can also cause swelling in the ankles when you have kidney disease, which then leads to an unfortunate cascade of needing water pills to get rid of that fluid, which taxes the kidneys even more. So, dietary restriction of protein, dietary restriction of salt is paramount. I can't emphasize it enough. Obviously, weight loss is important, smoking cessation is crucial, but just as an average patient, that's uh, that's something that we can't emphasize enough, which is protein restriction and salt and water restriction. Water restriction is a little controversial because if you restrict it excessively, obviously you're going to have some kidney problems. But most patients consume more water than is needed. And so, on average, about 1.5 to 2 liters a day is adequate for most patients who have an indoor lifestyle. I mean, if you're out playing tennis or mowing the lawn, of course, drink an extra half a liter to 1 liter on that day. But it's important to keep the water balance too.
Right, so that's great idea. So, let me summarize again to help the listeners. If you're diabetic, keep your sugars in good control. If you're hypertensive, keep your blood pressure in good control. If you have extra weight, uh, get the weight down, and calorie restriction will help. The exercise program will help the kidneys. What's good for the heart is good for the kidneys as well. So if you do Mediterranean diet, that's good for the heart, is good for the kidney, and Dr. Shetye will touch a little bit more about diet a little bit later. But plant-based diet, Mediterranean diet is important. So we need to push that. If you fluid restriction as you get worse with stage 4 or stage 5 is important. Salt restriction, potassium restriction, phosphorus and calcium. Those are more technical, and you need to see a dietitian who is well versed in chronic kidney disease to maybe get better literature. And National Kidney Foundation, we put a link on our comments today about how you can improve your chronic kidney disease from National Kidney Foundation. Great resource. You can download that. It's free. And then last not the least is, following through, as Dr. Shetye said, your things can change. You get a kidney stone, you get a UTI, you get a medication which can, make your kidneys worse. Let's say you have a hip pain and you start taking NSAID for a month. That's enough to put you from stage 4 to stage 5 very quickly. So it's very important to follow through if you're introducing a medication. Loretta had a comment regarding that, so let's bring that up. She's saying that between Tylenol, ibuprofen, which one is better to take? Tylenol does not seem to help. Ibuprofen does wonder. So that's a tricky question, Kedar. The answer is obvious. Tylenol. If you are asking a nephrologist, they will take Tylenol every day in their sleep. But what you tell your patient if they give you that answer?
So you're right. This is an issue that comes up quite often, and it's easy to be idealistic and say don't ever take any ibuprofen or Advil. And actually, some patients can handle Tylenol alone for their arthritic pain and get away with it. For the patients who can't, what I advise is to use the other pain medicines like Advil, ibuprofen, Aleve very judiciously. You know, if you have a particularly bad day when your back is hurting and you want to take a couple of Advils, that's fine. But don't make it a chronic habit where you take it every day. Because occasional use of Advil, ibuprofen, or what we call NSAIDs, NSAIDs, is not going to be that harmful as the chronic usage. Women who are menstruating, if they need it for 2 3 days to help them with their cramps, perfectly fine to take it. An athlete who sprains his ankle or her ankle wants to take it for 4 to 5 days, that's fine. But by and large, if your pain is so bad that you need to take Advil or Aleve or NSAIDs on a chronic basis, you're probably better off seeing a pain specialist to get more definitive treatment for that pain instead of burning up your kidneys.
That's a great point. Let me bring a slide again, and very interesting point on this slide from National Kidney Foundation, and I'll highlight this. The heart disease is major cause of death to all patients with CKD. So, people don't realize that the chronic kidney disease does not kill by itself. It can with other organs failing, but it's the heart disease which kills them. Let me get Kedar's input on that comment. So,
Yeah, so that's a connection that we recognized almost 20 years back. That, as you said earlier, whatever is good for the heart is good for the kidneys, and vice versa. If it's bad for the kidneys, is bad for your heart too. A lot of the unfortunate deaths that happen in patients with chronic kidney disease, and especially end-stage renal disease or dialysis patients, are connected to vascular damage, meaning blockage of the arteries to the heart, or caused by strokes, which is from blockage of the arteries to the brain. In fact, very sadly, about half the deaths in dialysis patients have nothing to do with dialysis. They have to do with heart disease, which is preventable. Uh, so, heart disease and prevention of cardiac complications plays a big role in us ensuring survival of dialysis patients. Uh, by definition, these patients need more intensive cardiac workup. They have coronary artery disease at a higher rate. They need stent placements. But all of that, I think, if you have a good nephrologist and a good primary team, you should be able to identify those issues preemptively,
right.
and you can be assured of a good outcome.
So we got a couple of your fans here. Let me bring them to the screen. Kedar, you're a rock star. There's Karthik saying he's watching you. and
Go,
then we
Karthik.
and then we got Sharon Reddy saying she's watching you, Dr. Shetye. Ray has a very interesting comment. Let's bring that up. And we get it all the time. I'm pretty sure you get it too. Uh, Thank you, Ray, for watching. Ray and Caroline watches a webcast, and they've become, we call them Dr. Ray and Dr. Caroline after they've been watching my webcast for the last 4 months. He's a very good guy with he does a lot of community education for UAW over the years. He's a local UAW guru, so he does a lot of work for the UAW. So he has a question about diabetics, CHF, and kidney. So let's take that myth out of the way.
Sure. So the question, I'm going to rephrase that, is do diuretics in the usage in congestive heart failure hurt the kidneys? Uh, so to put it real simplistically, and I'll expand on that in a minute, to put it simplistically, diuretics are what I call a necessary evil. So we use them to the extent that your heart failure requires you to use the diuretics, but no more than that. It's what I call the Goldilocks theory of medicine, which is you don't use too much diuretics, you don't use too little diuretics, but you use the amount of diuretics that are just enough for your heart to pump well. If you use more diuretics than is needed, your kidneys will suffer. And if you use less diuretics than are needed, your heart will suffer. So, in and of themselves, the diuretics are not hurting the kidneys, but they are actually helping to some extent by helping the heart pump better. But these diuretics have to be regulated very closely by the cardiologist, by the internist, and by the nephrologist. Of course, the best solution would be to watch your fluid and salt intake, because I have had many cases where just by educating patients about fluid and salt restriction, we have been able to get them off diuretics with an impressive improvement in the glomerular filtration rate or the kidney function. So again, simple things matter a lot in cardiac patients.
We got a couple of your other fans here. Kedar, you lit up our board today. We got, let's see, Rosie saying she's watching. Let's see who else is your fan here. We got
My
D. Williams saying she's watching, and we got Sharon Reddy. She's saying she's my doctor. So
yeah.
uh, thank you for guys watching, and let's move on to and more you're gonna put comments, more you're gonna be lined up for the I'm sorry, $25 gift card for Publix raffle next time. Which we'll do on the next webcast. And we have a phenomenal guest. We have a chief medical officer of Empath Hospice. She's going to talk about how the hospice and palliative care is relevant to senior population. So do tune in for the next. So let's talk quick Dr. Shetye's brain while we got in here. So let's talk, Kedar, about okay. So now you got a patient with chronic kidney disease, and we talked about how to keep their risk factors under control and what you tell them about diet. So give us a 5 minute skinny about chronic kidney disease and diet, and any of your favorite recipes.
Sure. So some of the diet issues we discussed, and I'll just recap them briefly, is protein restriction, salt restriction, and water restriction. But when you get to stage 4 and stage 5, especially if you're on dialysis, potassium and phosphorus restriction also becomes paramount. Some foods that patients with advanced kidney disease should avoid, and by that I'm talking about stage 4, stage 5, and dialysis patients. Uh, they should avoid orange juice or citrus products, should avoid uh, uh, potatoes. You can boil and peel potatoes, but not just boil them and eat them. It's important to have the potato leach out of the potato. It's important to have the potassium leach out of the potato before you use it. Clearly, we should avoid tomatoes, which are again rich in potassium. Uh, so this is around the time where we start referring patients to a dietitian for more specific food recommendations. Okay, bananas are another rich source of potassium that patients should avoid. And when I say avoid, I am not asking you to not take them at all. But if you're in the habit of eating 2 bananas a week, I suggest you go to 2 bananas a month. Okay, it'll help keep the potassium down and thus slow down the cut back on the likelihood of needing dialysis. Phosphorus is another dietary component that we regulate very strongly because high phosphorus in patients' bloodstream has been connected very intimately with heart disease. Phosphorus, unfortunately, is present in a lot of foods that we consume because it's there in our DNA. It's the backbone of the DNA is phosphoric acid. So it's hard to get away from phosphorus. But a diet that is more plant-based has definitely less phosphorus and therefore healthier than a diet that's animal-based. So having said that, it's recipes.
Let me just ask you a quick question here. There is plant-based protein. There's animal-based protein. And what I learned, in my dietary and nutrition classes is that you should have mix of both. And but the recent data is pointing more towards consuming more plant-based protein. What, how does it, impact in the chronic kidney disease realm?
Oh, it has a big impact. That's a good point you bring up. Plant-based protein is the way to go if you want to slow down the progression of kidney disease. And it doesn't mean you have to go completely vegetarian. Most patients do have a problem making such a drastic shift. And what I advise patients is you don't have to go fully vegetarian if you don't want to, but cut back on the amount of protein you consume. If you're going to have chicken, it should be about 3 ounces, which would be about the size of a deck of cards. Same thing for any red meat that you might want to have. If you just can't give it up, then limit yourself to 3 ounces or one deck of cards as far as size is concerned. But if you can make the change to plant-based protein, you are able to get away from the salt that's inherent in animal-based diet. You're able to get away from the cholesterol that's inherent in animal-based diet. And more importantly, the plant-based protein is easier for the kidneys to handle than animal-based protein. So to me, it's a complete win-win situation if you can switch over to a plant-based diet as much as possible.
That's a great point, Kedar. Thank you for clarifying. We briefly touched on that. Let me pick your brain on that. Why is that the Afro-American has four times more, hemodialysis or worsening of the kidney function? Same thing with the Pacific Islanders. Same thing, not as much, but Asian Americans also has higher risk of chronic kidney disease. Old age, we talked about that. Why these subset? Is it genetic? What's the take on these specific population?
So clearly, that story is being written even as we speak. But from the available data, part of the reason for the higher incidence of kidney disease, especially in African Americans, is the higher incidence of untreated diabetes or poorly treated diabetes, likewise poorly treated hypertension in the African American patient population. Another big factor is, of course, the socioeconomic conditions may not allow them to get the kind of health care that they deserve. These play a big role. There are some diseases that are more common among African Americans, such as focal segmental glomerulosclerosis. Uh, but these diseases per se account for a small number of the people that end up on dialysis. The vast majority of patients, African American patients who end on dialysis, it's because their blood pressure and diabetes was not adequately controlled several years before they enter the doctor's office or the nephrologist's office.
So that's a very important point. So it's nothing special about that group other than, as you pointed out, lack of access of care, maybe food deserts, where they live, they don't have access to good foods. The publics don't want to, let's not pick Publix, but any grocery store does not want to go in a, area which does not have enough income. So they have less access to, healthy diet, and they're more uh, prone to getting processed food, and they have less insurance access, or even if they have insurance, they are underinsured. Is there any cultural issues, like in certain population they don't want to see doctors as much, or what's your take on that? Is it inherently access issue?
A lot of it is access. Uh, to some extent, starting dialysis is tied in again with the educational level and the patient's insight into their disease process. So, what we often see, and this is anecdotal, is that some African American patients may not start dialysis at the recommended time because perhaps they're not educated well enough, or they don't feel confident enough that dialysis is going to solve a lot of their problems.
So it's more
So,
a education thing, like.
yes, sir.
So, okay, so, let's briefly talk about the symptoms. We didn't talk about the symptom. We though we know it, there are symptoms, but it's primarily silent. But it's good to know that if you're getting any progression, if you're CKD3A and now you're getting these symptoms, is it's time to get yourself checked. So, what are the symptoms? Let's go that through quickly.
Sure.
You feel more tired, have less energy, have trouble concentrating, poor appetite, trouble sleeping, muscle crampings at night, swollen feet and ankles, puffiness around eyes, especially in the morning, dry, itchy skin, need to urinate more, especially at night. There's one, thing we didn't talk was obstructive uropathy in seniors. If they have CKD3 in men, and then they have big prostate. In my practice, if I see them in the hospital, and you probably see in your rounds as well, you put a catheter in there, and suddenly in a day or two, the magic happens. So I think that's important point with our geriatric population to bring up is the prostate plays a role in making it worse. So peeing regularly, and if you're getting urinary retention symptoms, taking something like Flomax, or getting the roto-rooter job earlier than later can help preserve your kidney function. What's your take on that?
That's a very valid point in our population here in Florida, which is so much of it is geriatric. And I think one insight that I think the senior citizens can take away from this is just because you're urinating or going to the bathroom often doesn't mean everything is fine inside. Because if your prostate is big, the bladder is going to keep getting enlarged, and the urination may begin only after you've reached a certain critical volume of urine accumulated in your bladder, and you may not be emptying your bladder entirely. And to give a very simple analogy, it's like the overflow from a dam. Just because the dam is overflowing doesn't mean that the reservoir is empty. The reservoir is full and still the dam is overflowing. So it's important if you have prostate symptoms such as going to the bathroom multiple times at night or having unfortunate accidents when you least expect them, it's important to check if you're fully emptying your bladder. It can be done with a simple test in Dr. Mahajan's office or with a radiologist to see if your bladder is emptying fully. That's an important avoidable cause for kidney failure.
Yeah, thank you for clarifying that. And we a lot of time talk about other conditions and not talk about men-specific conditions. So I'm glad we got that out. Um, let's talk about end-stage renal disease. Let's say they tried everything what you recommended. They got their blood pressure under control, blood sugar under control, and they're still progressing to 15 or less. Um, what are the options they have at that point?
So, if you reach end stage renal disease, but typically what that means is you have reached a point where within a few weeks, the toxins that should have been excreted by the kidneys are going to reach such a high level that your brain is not going to function well and put you in a coma, or your heart is not going to function well and put you in heart failure, or your muscles won't function well, making it hard to even do basic work. And that stage is medically called uremia. We try to catch patients just before they reach uremia and shift them from that channel, so to speak, onto the dialysis track, where we then take out all those toxins through one of the diuretic processes. I'll go into those in a minute. It's important to realize a couple of things. We try to not start dialysis unless you have symptoms. They have done a couple of studies now, big studies, international studies, that looked at whether you should start dialysis early or later. And clearly, everybody was hoping that the later you start dialysis, the better the outcomes will be. And thankfully, that's exactly what the studies showed. So we start dialysis only when you have symptoms, when it looks like you might only have a few weeks before the uremic coma kicks in. If you are at that point, you got a couple of options. Hemodialysis, which is going to peritoneal dialysis, which is doing dialysis at home by yourself after training for a couple of weeks with a dialysis nurse. So peritoneal dialysis, it's called peritoneal because the lining of your belly is called peritoneum. This is a dialysis that you do at home. You're almost completely independent. It's very simple. In fact, it's so simple that you don't even need electricity to do it in its very basic form. As you can see on the screen, there's clean fluid in that blue bag that's entering the patient's belly. It sits there for about 2 hours, and then it gets drained into the bag that's sitting at the foot end of the patient over the next 10-15 minutes. And people now actually can do it while asleep. There's a machine that will run the fluid in and out of the patient while they're sleeping. So I know it might sound a bit science fiction-y to somebody that's not familiar with dialysis, but you basically hook yourself up to the machine when you go to bed, and the machine does the fluid in and fluid out 4 to 5 cycles at night. And so 8-10 hours later, when you wake up, you've had your dialysis and you can go and have a great day just like anybody without kidney disease. This is something that we recommend for working professionals or people who value their independence. Now, if that's not something that one is interested in, one can always do hemodialysis, which is using the blood vessels to do dialysis. And now that's something that very typically is done in a dialysis unit. Although a small number of very trained patients can even do it at home, but the vast majority do it in the dialysis unit, where you have the blood access. So a little bit of blood is drawn out at a time, sent through the dialysis machine, which purifies the blood, takes out the excess water, takes out the toxins that your body produces, and puts your own clean blood back into you. This process takes about 3.5 to 4 hours for the average patients, and we do it 3 times a week. There are some advantages to this procedure, to this kind of dialysis, in that you actually get seen by a nurse or a dietitian or a social worker 3 times a week, and it has some social benefits. People who are alone at home perhaps may find some camaraderie going to a dialysis unit. But we encourage home dialysis as much as possible. The federal government has launched a new initiative, I think it was launched last year, where they have a specific goal of making patients independent with their dialysis at home. And I think it's a very laudable initiative by the government. I think it'll, besides cutting down on costs, I think it will make dialysis a whole lot less cumbersome than it is at this point of time.
I have a few patients who have peritoneal dialysis, and I agree with you, Kedar. They like the independence. They don't have to, especially in COVID era. You're not indoor with other patients, and I had few patients, unfortunately, with dialysis who end up having COVID-19 from the dialysis places. Not that they are infested, but you guys do a good job there. But it's just the nature of the beast. You're sitting there for a long time, and they are chronically sick patient. They're very vulnerable. So, in COVID-19 era, or any patient who likes the independent, but logistics is a challenge. You got to manage, all the chemicals, and you have to be a little bit more, have support, maybe your kid, maybe someone who can help you, or you're more agile. So as you said, working the peritoneal dialysis is fantastic, and home hemodialysis is even gain value there because of same reasons. You're not in contact with other people in COVID era, and also I think infection rate, because you are in your own microbiome, you're not with other patients, so the nurses and the contact will be less. So that's what I see in my hospital practice. One of the main, uh, one of the reasons for the end-stage renal disease patient to get admitted is sepsis. That means the blood getting infected because there is direct access. So that's easy. So that gets less with home hemodialysis. Anything else other than the peritoneal dialysis in Horizon hemodialysis? What you can tell us for end-stage renal disease patient? I know there is renal transplant at Largo Medical Center. You're part of that, so tell us a little bit about it and anything else you have seen in your research and reading.
Sure. So the third option, besides hemodialysis and peritoneal dialysis, is the best option, which is kidney transplant. I mean, if you ask a kidney specialist like me, what would I prefer if my kidneys ever failed? That's going to be my answer. Right? Give me a kidney transplant. And luckily, we have right here in our backyard a great institution that does kidney transplants. In fact, I was just talking with Dr. Mahajan, the main transplant surgeon, and over the last 5 years, we've done 180 kidney transplants, and our survival rate is better than the national average. So we've done excellent work here, right here in our own backyard at Largo Medical Center. We actually are also, I think, the there's a move to giving kidneys to your own family members. It's called living related donor or living unrelated donor, where you donate, a person donates a kidney to somebody that needs it, instead of that unfortunate patient having to wait for somebody to pass away before those organs are donated. And in that sense, we are ahead of the national curve. We have about 30 to 35% of our transplants occurring from living donors compared to the national average of about 20 or 23%. So kidney transplant right here in our backyard, I think it's one of the best things that could happen to Pinellas County.
And it's good to heartening to know that your outcomes in the institute is good. Dr. Mohammed is a fantastic, very well trained surgeon. If my memory served me well, he came from Tampa Journal where he had very good success rate as well. So it's good to have that option. Any cadaveric organ or any other fancy stuff in the petri dish organ generation, pig organs, anything fancy you can tell us?
Well, they are trying to come up with the artificial kidney construct. That is still not in the clinical trial phase, but basically it's a 3D engineering of the kidney, which is a little more challenging than 3D engineering or 3D printing of other organs because of the way the kidney cells are lined up in the nephrons, which is the structural unit of the kidney. But it's being looked at. I don't think anything is going to be available for another 5 years at the at the earliest. But that's on the horizon. I'm looking forward to something like that becoming mainstream, because that's where really the answer lies for a lot of our patients. Right now, only 1 in 4 patients who needs a kidney transplant gets it. The other 3 out of 4, unfortunately, never end up getting a kidney transplant. So I'm hoping 3D printing of kidneys gives us the solution that we have waited for many decades now.
What's the average life expectancy? Let's say they are contraindication, their age 65 and above, they can't get kidney. Once you get on hemodialysis, what's the average lifespan on these patients?
So there's an absolute cutoff for kidney transplant, that is 80 years of age. But anybody above 70, we will look real closely, because sometimes they might not have a good outcome. So anything below 70, as long as the patient is reasonably healthy, is a great candidate for a kidney transplant. Anybody above 80 is not, and then 70 to 80 is a bit of a gray zone. Survival of patients after a kidney transplant is measured in decades. And you might have a kidney itself that lasts 10, 15 years, and then you might have a short stay on dialysis for a couple of years before you get your next kidney transplant. So if you get a transplant, your survival is in decades. And that's why transplantation is so much important, because if you look at dialysis, whether it's hemodialysis or peritoneal dialysis, the survival, of course, is variable depending on the individual patient, but about 5 to 7 years would be more mainstream for our patient population. So you can see right there the contrast between the two therapies, which is why we like to enroll as many patients as we can for a kidney transplant.
Anything? I know we covered a whole breadth of topic, and that's your whole fellowship right there. The nephrology we covered in 35, 40 minutes. Anything which we didn't talk about you want to bring up?
Um, I think the the key is to stay healthy. And people don't have to worry about kidney disease if you're not obese, if you don't smoke, if your blood pressure is under control. Uh, People don't realize that kidney disease is nothing exotic. It's a byproduct of a unhealthy lifestyle or unhealthy choices. The best way to get rid of kidney disease from society would be the preventive options of controlling blood pressure, controlling diabetes, weight management. Uh, there are some kidney diseases that are not lifestyle diseases, such as glomerulonephritis, IgA nephropathy, genetic diseases like polycystic kidney diseases. And there are advances being made on that too. But by and large, this is a preventable disease. This is a controllable disease. Uh, it would be a great time for me if I were to put less people on dialysis and more people just being seen in the office, because to me that would be success. The less people that have to go on dialysis, I look upon it as a yardstick of my professional success.
I think that's a great point, and I think that's where the teamwork between the nephrologists and primary care will shine. If we can help patient make those lifestyle changes, what you alluded to, losing weight, keeping your blood pressure tight, watching your salt, more DASH diet or Mediterranean diet, which is plant-based diets, more exercise, quitting smoking. What's good for your heart? Just remember, it's good for your kidneys, it's good for your brain, good for rest of your body too. If you don't have heart beating, you got nothing beating. So if you can think of anything which will help your heart, will help every organ, including kidneys. As you said, it's not exotic. It's just everything talks to each other. If you are having a stressful life, it's going to hurt your heart. It's going to hurt your kidneys. So, and that's where we're going to go to the next piece of our talk, Kedar, and you can hang out. We're going to do three-part breathing. Every talk, we end up with teaching our patients a tool to improve their, the COVID and lifestyle changes in the COVID and isolation, mental health is becoming an important topic. So I try to teach them some breathing techniques. So if you want to hang out, we're going to teach them three-part breathing today. So let's get going, guys. If you have any questions for Dr. Shetye, put in the comments and we'll do that. And with that, Kedar, thank you so much for joining. You can hang out and watch me do the three-part breathing. If you
Thank
want.
you. Thanks for having me.
Thank you, Kedar. Let's see if you have a question. Let's see. Loretta is saying it's not easy. Yes, lifestyle changes are not easy, Loretta. But the rewards. If you don't have health, you got nothing as you get older. You may have as much money, but if you can't walk, you can't, live without dialysis. It's difficult. You will end up in the hospital or dialysis center very frequently. So, if we can, as Kedar said, make changes early on before you get to stage 3B plus, and even if you're there 3B4 and you make dramatic changes in your lifestyle, and sleeping good too. Sleeping is another important point we don't bring up, but sleep apnea and sleep is important to address as well. And that helps your heart, it helps your kidneys too. So yes, hydration, sleep, uh, eating well, all those things, as Kedar alluded to, is difficult, but you got to take one step at a time. Just change one thing. If you can just add more plant-based diet for next 6 months, just focus on that. Rest will follow. Or get a Fitbit or an Apple Watch, add 5,000 steps, 2,000 steps, 3,000 steps based on your level. Just do one change. And in my experience, Kedar, if you make one good change, the other changes are part of it. So so yes, it's difficult, but let's do one thing at a time, right?
I agree, absolutely.
Yeah,
Small and steady steps get you there. When I talk about weight loss with my patients, I tell them to keep it simple. Maybe 1 pound a month, 2 pounds a month. Don't try to achieve some world record because this is a marathon. Your life is a marathon. It's not a little sprint.
exactly, exactly. Great piece of advice. Let's do the breathing, and let me get you out of the screen. Thank you so much, Kedar. All right, so guys, the three-part breathing we done before. It's not hard. What it does is it helps you get your diaphragmatic muscles and your uh, abdominal muscles in play. Typically, in our busy life, we end up just using the shallow muscles, the smaller muscles, the intercostal muscles. But if you can incorporate, all three parts, which is the abdominal muscles, the diaphragmatic muscles, and the intercostal muscles, then you can expand your lungs better, and you can have better sleep too if you use that before sleep, or if you're getting stressed out, you can lay down and do it for 5 to 10 minutes. That will improve your relaxation. So let's do it. So first step is just to understand when you inhale, you make your belly bigger. So let's do that. Let's do a deep inhalation. Breathe in with me and then breathe out. So the belly should go forward in the inhalation and the belly should go back in the exhalation. The next step is including your diaphragm. So breathe in with me with your belly, and the belly should balloon up. Now add a little bit breath around your diaphragm. So now you got the second part of the three-part breathing done, and then breathe out, stay tall through your chest first, and then your belly. And the exhalation should be always longer than your inhalation, and always exhale through your nose. Now let's add the third part of the three-part breathing, which is raising your heart up and the intercostal muscle just below your clavicle. So let's breathe in through your belly again. The best way to do it, if you lay down and bend your knees and you can watch your belly go up and down, watch your chest expand and relax. So if you can do it with no shirt on and just watch your different parts, that'll give you a better sense of the three-part breathing. If not, if you're sitting up, that's okay as well. All right, let's do the three parts all together. Breathe in, make your belly get bigger. Add a little bit breath around your diaphragm. And then another piece of breath on top of your chest. Now stay tall and breathe out through your first part and all the way to your belly. Let's do all three without stopping this time. And then hold one, two, three, and then breathe out from your chest down. Stay tall. Let's do two more time and close your eyes this time. One more time. And the last time. See, it was not that hard. If you practice that 10 minutes, three times a day, it will expand your lungs and make you relax, and you can do it just before you go to sleep. We appreciate Dr. Shetye coming in and sharing the wisdom about chronic kidney disease with us. I'm going to do a quick uh, uh, drum roll, and we'll get the winner of our previous raffle. So let me bring the. Here we go. So we got our drum, and we're going to shake it around. What we doing the raffle is for the Publix gift card. Let me show you. So that's a $25 gift card we're giving out for the people who put comments on our show last time, and all the people who put comments today. And even if you come back from work and put the comment, you'll be for the raffle for $25 gift card for the next show. So let me put up a slip here. Let's put this away. All right, and let's see who's the winner. The winner is Deanna Fink. Miss Fink has been a very good supporter of our webcast from the get-go. Congratulations, Diana, for winning the $25 gift cards. If you're listening, please add a comment. You can say, hi, Dr. Mahajan, hi, Dr. Shetye. If you have any questions, put that in, and I'll address that, and I'll work with Dr. Shetye on your questions. Again, I appreciate you tuning in, and we're going to join with the Chief Medical Officer of Empath Hospice for Pinellas County in the next webcast, and that's going to be very illuminating as well, how hospice, and as we have misconceptions about hospice as end of life, it could be a lot of other things. So thank you, and thank you for tuning in. Be nice to yourself, be nice to your fellow human being, be nice to biosphere and planet Earth. And we'll see you on next Thursday at 4:30. Ciao.